And now we're going to switch over to Jacob Bohr, who's assistant professor and the Peter T. Paul Career Development Professor in the Department of Global Health at Boston University School of Public Health. His research applies to the tools of economics, epidemiology, and data science to the study of population health with a focus on HIV treatment and prevention in Southern Africa. His current research interests include economic spillover effects of HIV treatment on patients, households, and communities, decision-making in HIV endemic risk environments, population health impacts of social policy, and causal inference in public health and epidemiologic research. His work has been published in journals such as Science, Epidemiology, Lancet, and PLOS Medicine. And prior to his graduate training at Harvard School of Public Health, Dr. Bohr worked with an HIV prevention NGO in Botswana, Lesotho, and South Africa. So with that, welcome.
Great, thank you very much. Can everybody hear me?
Yes, perfect.
Excellent. I should have given you a shorter bio. My apologies.
No, it was really interesting, and I was really proud that I was able to get some of the big words out right.
Well, so as you can see, I come later than probably everyone else here to data science. My background is in epidemiology and economics, but I'm based at a school of public health. And work with a group of collaborators who have been working on questions around HIV treatment and prevention in Southern Africa for quite some time now. And just sort of thinking about the US relevance of this, a lot of the funding comes through USAID and CDC through the President's Emergency Program for AIDS relief. And South Africa, where this work is based, has been a major area of investment on the technical assistance side more than the direct drug provision side. And so this sort of falls into some of that technical assistance work while at the same time creating really cool opportunities for research. So let me dive in. So I'll talk about a record linkage project where we work with South Africa's National Health Laboratory Service to create a first national HIV cohort in any lower middle income country and propose this as a novel platform for HIV policy evaluation. So here's the big picture questions. There are now very large chronic disease epidemics worldwide. Chronic diseases are the leading cause of morbidity and mortality in middle income countries and present a major health systems challenge. In a lot of developing countries, health systems were really developed to provide acute care for infections and emergencies and mom and kids care for vaccinations and births. And so we're asking now health systems to do something differently in managing chronic disease because it requires a longitudinal relationship with patients over a long period of time. And there's a key role, obviously, there of data to both manage care at the individual level and also to inform policy. So in lower resource settings, chronic disease management is essentially iterative collection of biomarkers. In HIV, a CD4 counter-viral load, in diabetes, an A1C or blood glucose, et cetera, and then a clinical action on the basis of that biomarker. And it's quite algorithmic. And the advantage of that is you can have lower skilled cadres of health workers with less training provide evidence-based healthcare at scale and to large populations quite quickly. So there's an opportunity there to optimize those rules, and to do that, one needs data and databases. So HIV is a manageable chronic disease now. There are 37 million people globally who have HIV, and 1 in 5 of those lives in South Africa. South Africa scaled up antiretroviral therapy for HIV starting in 2004. ART allows someone with HIV to have near normal life expectancy. It's really been a miracle drug or set of drugs. And in recent years, the evidence has accumulated that ARVs don't just improve someone's health, but also essentially eliminate onward transmission of the virus. And so there's now this new and ambitious paradigm of essentially trying to treat everyone in order to prevent onward infections and to actually end the epidemic. And South Africa and other countries have now moved towards this with the goal of trying to get everybody in care and on therapy and retained on therapy. That will be hard. And there are lots of reasons why each of those steps along this so-called treatment cascade is difficult. But I'll focus more on the data side, which is that currently there's no data set that provides a system-wide longitudinal perspective on this HIV cascade of care from the point of diagnosis and linkage to a facility, to initiation of treatment, and on to viral suppression, including following people as they move around the health system to different facilities in this highly mobile setting. So the National Health Laboratory Service is the sole provider for South Africa's national HIV program. They have done about 40 million CD4 count and viral loads since 2004. And essentially, any HIV monitoring is done by NHLS. There's one province that joined in 2010, but other than that, we essentially have data for the entire public sector HIV program. This work builds on a longstanding collaboration between Boston University, the NHLS, and HERO, which is the Health Economics and Epidemiology Research Office at the University of Witwatersrand in Johannesburg, South Africa. And this has been so this particular activity comes sort of on the heels of several other activities in which we've supported NHLS in their work. The data are high quality in the sense that they are the exact data used in patient care, and even and what we have access to are the data before they've even been sent back to the clinic. So a lot of times data are extracted from charts where they have to have been written down, where they have to have been acted upon before being written down and received from the lab. And so during all those steps, there's opportunity for error. And so we have high quality data in that it precedes that. It's system-wide and continuously updated. And the major limitation is that up to this point, there's been no unique patient identifier. So our question was, can we build a national HIV cohort from these data? So I've said this. We follow standard sort of procedures here for record linkage with a few twists. So we pre-process the data, and then we search for potential matches between different iterations, different observations of potential patients, and we have to obviously do this within blocks because it's a very large problem otherwise, and so we do multiple blocking passes in order to identify candidate matches. We use the Flagey-Sunter methods to score those edges. And then the sort of traditional approach to determining whether something's a match or not is to identify a lower threshold, a higher threshold, and then an area in the middle, which would be held back for manual review. Well, our problem is big enough that it was essentially not practical to do manual review here. And so what we did was, instead, we said, can we use some information about the network structure or graph structure of these potential patients to say, is this plausibly an individual? And what this does is it prevents this sort of blowing up of large clusters, which can be identified as not plausible patients. So here's a case where I happen to be falsely linked with Jason Bourne, which we know that we're not the same person. And so we have in ongoing work, we're working with some faculty in computer science at BU to develop some new graph-based linkage techniques. What we're doing so far is quite simple in terms of a threshold rule on weighted diameter, and requiring that a cluster is essentially sufficiently small in order to accept it. So the results of our linkage is we started with about 40 million lab results, of which there were about 19 million exact matches. And we linked that down to about 9 million unique patients identified as this national patient cohort. Of these, about 40% are single CD4 counts. And this is consistent with anecdotal evidence that many people show up, test positive, have blood drawn for CD4 count, but never return to care. We identified 3.1 million patients on antiretroviral therapy and virologically monitored, which compares to the 3 million reported by the National Department of Health. And I'll show just a few sort of teaser early findings from this work in terms of ways that we are trying to use these data to evaluate policy and to inform the next wave of the response. So can South Africa actually treat everybody? Well, on the one hand, we do see that patients are presenting for care earlier in infection than ever before. So first CD4 count at presentation to care is a measure of patients' health. And so their health is improving over time. The health of patients is improving over time in terms of patients when they first present. Although still at about 325 in 2017, it's not that high. And there are many people who present still quite late at lower CD4 counts. And the recent policy is essentially to extend eligibility for treatment to people who present with CD4 counts above 500. What you can see from this histogram is that only maybe a third here of patients are actually affected by that policy, because most patients are still presenting quite late. There's substantial heterogeneity by gender and district, and we have this down to the facility level, and there's potential to think about high-performing facilities and facilities where there's unmet need that could be targeted for further intervention. This plot shows the relationship between first CD4 count and whether a patient proceeded to have a treatment lab workup. So before being initiated on treatment, there's a set of lab tests that are done to make sure that there are no adverse reactions. And so what you see, what you see here is in the prior regime, before the implementation of this eligibility expansion, there was a significant discontinuity at 500, which was the prior eligibility threshold. So if you presented below 500, about 40% went on to a lab workup. And if you presented above 500, about 15% had a lab workup. So extending eligibility to these people above 500 is going to have a substantial impact on their progression to initiation of therapy. So that's the good news. Of course, the bad news is that lots of patients are not starting even though they're eligible. And so this highlights a major gap in place where much more work needs to be done to figure out why patients are not starting, and to again to identify facilities that are doing better and those that are doing worse. One of the benefits of what we're able to do here is that we can follow patients as they proceed through the ART program. So the red line here shows the proportion who are retained at their initiating clinic where they started treatment. And this falls off quite precipitously, and is a pretty bad news story, frankly, that has colored a lot of the discussion around retention and care. But actually, if you look within the whole national treatment program and allow people to move across facilities, the picture is much better. And so we're able to show this with these data in a way that hasn't been seen before. So can South Africa treat all? Well, perhaps, but further efforts are clearly needed to increase early diagnosis and linkage, and to increase ART uptake amongst those who are offered therapy. So I've shown our record linkage process and some few examples of how this work the implications of this work, but we really see this in the context of a larger project where sort of starting at 12 o'clock and moving counterclockwise, there's the methods development aspect of thinking about how to incorporate graph-based methods in record linkage, and thinking about statistical uncertainty when you have clustered data. potential additional patient linkage with other individual level data sets in existing clinical cohorts, potential to integrate this cohort into systems of clinical care. We're already sending reports to clinics of patients who have elevated viral loads for them to act on. And that's a sort of an intervention that we're looking to evaluate. There are clinical epidemiology questions, can be used for continuous quality improvement and sort of rapid policy evaluations when to evaluate new policies that are rolled out. And finally, because the underlying denominator is essentially the complete population of South Africa, there's an opportunity, or at least the 90% that use the public sector, there's an opportunity to link this to external data sets and think about this cohort as actually the exposure to look at health systems interventions and their effect on other outcomes at the population level, and actually think about population health impacts of health policy. Of course, finally, there are questions about sort of ethics and security questions in all of the linkage to additional databases, and we're working with our South African colleagues to embed all of this in their systems there. And so that is sort of a snapshot of this agenda. We've benefited from some funding from NIH and are looking for more. So that's where we are with all this. I really appreciate your time and your comments.
Jacob thinks that's so interesting, and yes, I think all of us probably have that in common, continually being on the hunt for funding to keep the good work going. Let me open it up for questions.
This is Florence. I have a question for both of our presenters. So as I think about the data sharing challenges that you're having, Kelly, you were talking about zettabytes, which is just before yottabytes and brontobytes, pretty high. But then again, you have to do cleansing of the data before you do a lot of sharing, or do you do sharing to do the cleansing? And then Jacob, what your data sharing challenges might be, because that's what we're trying to address in these big data hubs, is to understand data sharing challenges, whether it's bandwidth or trust and identity software, whatever it is that's needed. That's what we're looking for. And healthcare and life sciences is the huge growth platform for benefits to society and us humans. And so I'm wondering, if you all want to share anything about your specific data sharing challenges you'd like us to think about.
Well, so I can probably give you the shorter answer, because I think Jacob probably working with population health. We are working with the UT system in Houston School of Public Health. They really know much more about data sharing than we do. We know about how to archive it, and we know how to structure it such that we can get fast computation and fast access. But there are an enormous number of issues surrounding sharing that I don't feel like I'm the best person to answer. But I can tell you from the data sets that we do have, we cleanse them before anybody else sees them. We cleanse them before we do anything on it so that we can verify that the data is good. Beyond that, we don't really share the data sets. We partner with the people who are really well versed at managing all of the policies and managing, we provide the infrastructure, and we advise on architecture for scale and for fast access.
Yeah, I would say that I'm not an expert in this side of it. NHLS owns the data, and we see our role as providing a service to NHLS, which has the results of the linkage are turned over to them, and if one needs access to the data, it goes through NHLS. And I think particularly working internationally, there are sovereignty issues that arise that it's of all the things in our work, to be honest, it's something that we take very seriously, but it's not something that we push much on, because we are, it's it's their data.
Yeah.
So I think there are questions in terms of the future of this project when we talk about how to link with other outside of NHLS to other potentially individually identifiable data sets, where those questions start to come in. And I think we're just at the beginning of even thinking about that. I wish I sort of had more to say on this, but I think that we're not the resource NHLS is, and we've provided a service to them, which is also obviously an opportunity to do research with these data.
I will tell you, I'll give you a compelling problem that we are unable to do because of data sharing and privacy restrictions. So maternal mortality is a rare outcome. So there's roughly 28 to 30 women in the state of Texas. And so it goes roughly by scale, very small percentage that die every year, but it's almost 100% preventable. I can get a hold of birth data, but it doesn't identify mom. And I can get a hold of death data, but it's scrubbed so that rare events don't appear. So if you go and look at the CDC data, we went to National Vital Statistics and asked them if we could get access, told them what the program was. We have an IRB. The response that they gave us was that it is very unlikely. Well, one, the US actually pays money for a third-party contractor to actually hold all this data, and then it charges the US back for access. So the US doesn't really own the data, this third party does, and the third party won't give access to it because you will be able to identify individuals even if you go through. So they'll allow you access on their computers to do their things on sort of a server-based model, but they won't allow you to take the data out so that you can try to link and match it and then do these studies. We were told that we should probably start collecting them as we see them going here forward. The problem with that is it's going to take about 10 years before I have enough data so that I can really get anything meaningful out of it.
To get statistically significant, yeah.
That's right. And what they said to us was that there are HIPAA laws, and then there are the US government laws that govern people who hold our national statistics. They are considered the keeper of national statistics, and they don't let that data go. And I said, well, then how are you ever going to identify any rare outcomes or causes? He said, we're not.
Huh.
Yeah.
There was a doctor, I forget, it was in a HIMSS document or Health IT Security or something, and he said, we've lost more patients by not sharing data than by sharing data.
Yes.
Yeah.
Now, in other countries, I think is it the Netherlands or Switzerland, somewhere over there, they have a national registry. I know New Zealand does because I've talked to them as well. They have a national registry where everyone participates. It's just, it's culturally expected that you contribute back for the betterment of society as a whole. We don't subscribe to that policy. I think we subscribe more to privacy first.
Yeah. This has been very educational. Thank you both very much.
Privacy first in the public sector.
Yeah. Yes. Right. Yeah. Right.
I mean, and I think that's actually worth a broader conversation, right? I mean, people's attitudes towards privacy are changing, and where there are low-hanging fruit, where there be clear benefits. Obviously, rules can be put in place, but it seems like there should be re-engagement with this discussion about some of the public sector data.
Well, I think, Jacob, you just touched on it, this concept that maybe the sale to an American audience or audiences with similar values where the individual's needs come before the greater good, say, versus like a Confucian influenced society, that we need to just demonstrate that your self-interest is best served by the sharing of data so that you can reap the benefits of these discoveries and live a healthier, longer life.
Yep.
Any other questions for either Jacob or Kelly? Okay, well, with that.